morning, dear colleagues, dear lecturers and partners of this workshop. On behalf of all lecturers of this workshop, I would like to thank the Scientific and Organizing Committee of ICE's meeting for giving us the opportunity to be here with you. This is the workshop for autonomic dysreflexia after spinal cord injury, debates and controversies. We are going to bring in front of your knowledge the AD phenomenon from different aspects of view. I'm going to present to you each lecturer before his lecture. You have the program in your hands, and the full handouts of all lectures are available via ICS website. The new thing for this year is that you can complete the evaluation for this workshop having downloaded the application in your smartphone. The first step is to select the program, to locate the workshop, then scroll down and find the evaluation button and complete the survey. And at this point, I would like to ask you if everybody is familiar with autonomic dysreflexia. Autonomic dysreflexia is a potentially life-threatening acute condition due to an excessive, uncontrolled sympathetic output leading to excessive bladder pressure increase. And this is triggered by noxious or non-noxious stimulus below the level of the injury. At this point, we're starting the first controversy about how the AD episodes, if are easily treated, and I'm going to post for this. I am a rehabilitation physician from Greece, and I have a special interest in spinal cord injuries and bladder and bowel dysfunction, and how difficulty are the episodes treated will be posted by Professor Andrei Krasyukov. He is a rehabilitation doctor from Canada, Associated Director and Scientist of ICORD, Director of Autonomic Research Unit and Spinal Cord Program of the University of British Columbia, and Professor of Rehabilitation of Western Ontario, London. So I could finish my lecture with this. Yes, the autonomic dysreflexia episodes are easily treated when we have early diagnosis, high index of suspicion, and remember that symptoms may remain minimal. Who and when may have an episode of AD? Persons with spinal cord injury above T6 level. The severity of the episode is related to the higher level and the completeness of the lesion. When? Usually, episodes occur post-spinal cord shock in the chronic phase, but in rare cases may occur during the acute phase as well. Why? In the vast majority, the distension and contraction of hollow organs is the triggering stimuli. And this is, of course, bladder and bowel. And maybe activation of pain receptors, and here you can see a lot of these. And please have your attention that tetraplegic persons cannot feel if they have a heart attack, as you can see from this. You see, after a spinal cord injury, the sympathetic nervous system is very severely damaged. On the contrary, the parasympathetic system bypasses the spinal cord in a great portion by 10th cranial nerve. And this is the reason, this imbalanced damage that makes this phenomenon. So how will we make the early diagnosis? Recognize the symptoms: feeling of great anxiety, pounding headache, stuffy nose, piloerection, flushing and sweating above the level and sometimes sweating below the level, paling and vasoconstriction below the level, slow heart rate usually, breathing difficulty, blurring of vision, nausea. Also, we have to recognize the signs. Check the bladder pressure. Sudden and significant increase may be a sign. But what do we mean significant increase? The increase more than 20 to 40 millimeters of mercury above the baseline of blood pressure. And this baseline blood pressure for people with spinal cord injury above T6 is no more than 90 or 110. That means that a person when comes with 120 blood pressure may have autonomic dysreflexia. We have different levels of the severity of episode, and we have to remember that one episode may develop from one level to the other when this is not diagnosed in time and treated appropriately. So we have to have a high index of suspicion to be in time with our diagnosis for autonomic dysreflexia. Sometimes there are not so common noxious stimuli, and this is the problem. You can see here Syrgomyelia. Syrgomyelia is with symptoms is not so common, and the symptoms usually is pain and movement deficit, and only in rare cases maybe only autonomic dysreflexia symptoms. As well, discovertible lesions below the injury level and sarcoarthropathy. So, when we have unexplained autonomic dysreflexia episodes, we need thorough checkup of the person with spinal cord injury, and we have to find the correct diagnosis of the underlying triggering cause, so to have the treatment and resolve the problem. For this, for the in-time diagnosis, we need proper education of patients and caregivers, so to be able to realize the symptoms by themselves, and we have to educate health professionals not familiar with spinal cord injury. So a medical emergency card is needed in the national languages and English, endorsed by scientific committees, and with individualized information and history of the episodes. This is very helpful for the management. At this point, I would like to stress out the importance of ISAFSCI, the international standards for autonomic dysfunction. Having completed this for every person with spinal cord injury, we make it more easy to identify acceptable persons and treat them as they have to be treated. So what to do to treat easily? At first, not pharmacologic measures, sit patient upright, monitor blood pressure every 3 to 5 minutes, find and eliminate the triggering cause. And if the blood pressure remains elevated, then some type of pharmacologic agent if we have more, as you can see, 150 millimeters of mercury. And here we can have a long discussion, I think. Above all, prevention of stimuli. This is the best treatment. Good management of bladder, bowel, skill, musculoskeletal health. Okay, we find the cause and resolve it, but we have to remember the phenomenon of silent AD, which is raised blood pressure without other symptoms, and this may mislead the early diagnosis. And do not forget that the incidence of episodes may be underestimated because usually we have intermittent monitoring of blood pressures. This we have to remember, all of us. So, take-home message is treatment of autonomic dysreflexia is easy. Under special conditions, the episodes are self-limited if diagnosed in time and after the removal of the underlying stimuli. Thank you for your attention. The discussion will take part after finishing all the lectures. And at this point, I would like to ask Professor Krasyukov to post for the opposite side of the treatment.